So hello students, today most of you have done your Neet-Pg 2021 exam well. So things apart, so if you find you need to improve upon yourself, you need to definitely revise the paper which was asked today. So you should definitely go through the paper. You should answer and watch all the recall videos so that you will have a better revision. So this video is mainly for the people appearing for the next NEET. So if you are appearing for next NEET, you just have a go through in this video, because this NEET paper is full of surprises. So ENT is not a exception for that also. So I'll start with the question. So totally 8 questions have been asked directly from ENT, 1 or 2 questions asked indirect from ENT. So I'll deal with that 8 questions. The trend changing paper. So the trend changing that is high yield topics are ignored in this NEET paper. So there are many high yield topics generally, like IPC sections, like COVID. Even COVID, not much questions has been asked. Okay, in ENT also, content wise, here is the biggest chapter, but here only one question has been asked. Nose, 2 questions has been asked, but throat, 5 questions has been asked. This is really a trend changing paper. So if you focus only on high yield topics, then you going to suffer in the forthcoming NEET. So what you have to do? You need to study upon all the topics. You need to have basic understanding of all the topics. Then you should approach all the topics in a bird's eye view. So then you can memorize important things. But from here onwards, the thing that is very much important is clinical stuff. So every disease you study, you imagine it with the patient. Every clinical sign you study, you should imagine with that you are inside a ward, what you are going to do for a patient. So I'll start. Yeah, 42 years old male presented with chronic ear pain and discharge. So chronic ear pain and discharge, so it gives chronic otitis media as a clue. So now see, the patient is having headache and vomiting. So headache and vomiting, in which are all these conditions, the headache and vomiting will be there. First option, meningitis, surely there will be headache. So all these cerebellar, temporal, extradural abscess, all these will be, these are all space occupying lesions. So definitely there will be headache and vomiting. So the thing is the radiological diagnosis. So this is typically a ring enhancing lesion found at the temporal lobe. Fine. So history wise, we can't delineate the answer. CT wise, we can say it as temporal lobe abscess. So what are all the things that you could expect in this intracranial complication? It is being given in our workbook, page 77, intracranial complication. The intracranial complication, I would deal with the help of a temporal bone. The temporal bone, Peter's part of the temporal bone is much important. So many intracranial complication can occur if the infection breaches the Peter's part of the temporal bone. If the infection breaches the Peter's part of the temporal bone, immediately it can go superiorly to reach the temporal lobe. So medially to reach the cerebellar region. Fine. Then it can cause extradural, then subdural. These are abscess. Fine. So this thing has been asked. Okay. Then meningitis. Okay. Then what else? So it can spread to even brainstem. These are the possible modes of spread of the unsafe type. So Now, safe type, unsafe type, both can cause complications of CSOM, COM. The name CSOM has been changed to COM. They can ask. So, see, now in this paper, no question, almost nothing has carry an diagnosis part. They have not given the diagnosis of the disease in anywhere. So they're just giving the symptoms. So with the symptoms, you should sort out the diagnosis. So with the symptoms, we are having chronic otitis media. It can be safe or unsafe type. Here, most commonly unsafe type could be the thing. So after reaching the pituitary for the temporal bone, it can reach the other areas of the brain. So most common, it can go to the temporal lobe. So if it is a temporal lobe abscess, he can have fever, headache, and most importantly, the temporal lobe is affected. So there will be nominal aphasia. In cerebral lesion, loss of coordination. So these two, extradural and intradural, only space occupying lesion symptoms. Okay. In meningitis, there will be neck rigidity. That is the standard thing. If it goes to the brainstem lesion, again, it can cause lower cranial nerve lesions. So these are the things. Intracranial complications of the chronic otitis media. Fine. So now temporal lobe abscess has been asked. So we should diagnose temporal lobe abscess based on the CT finding. So it can be, if it comes over the here, it can be extradural abscess. It can be an intradural abscess. Meningitis, there is no organic lesion. That is only inflammation of the meninges. So if there is a cerebellar abscess, there will be somewhere around here. So based on the location of the CT finding, we are coming out with the diagnosis in this question. So next question, a patient presented with merciful anosmia. This is a spot out diagnosis and foul smelling discharge and occasional epistaxis. What will you find on nasal cavity examination? See, all questions they are giving a clinical scenario. Either they are giving an examination point, either they are giving a management part. What will you do next? So these are the most common mode of question they are asking, right? So this is part out diagnosis for atrophic rhinitis. So in atrophic rhinitis, there will be atrophy of all nasal turbinates. So there will be roomy nasal cavity. That is the answer for this. See, we have given this in page 183 of our workbook. So atrophic rhinitis, the causative organism is Klebsiella ozonae, most important. So that is otherwise called ozonae. Other bacteria, they can ask it as a for 3 option MCQ. None of them like that. They can ask Coccobacillus, diphtheroids, Bacillus mucosis are very rare causes for atrophic rhinitis. Then the pathogenesis is based on mechanical theory of Zophal. Okay, the bacteria causing recurrent inflammation that is leading to thrombus leading to atrophy. So this could be the possible etiology device proposed by Zophal. So presentation very important. Greenish crusting, foul smelling, but the patient will not smell his own bad odor. So there will be merciful anosmia. Fine. This is atrophic rhinitis. The treatment part is important. G plus G. I used to say it as 25% glucose plus glycerol. BBC. Sodium bicarbonate. Sodium biborate. Sodium chloride. This is a solution given for nasal douching. So 2:1:1 ratio we should give the nasal douching. What is DDC? This is anti-ozone solution or chemisetting solution. Fine. Here there will be DDC, estradiol vitamin D chloramphenicol. So these are the three components of anti-ozone solution. Antibiotics, so we can give gram negative cover antibiotics. Then vitamin A and vitamin E can also be given for atrophic rhinitis. So it is very simple. If the nasal cavity is there, there will be atrophy of middle turbinate, inferior turbinate due to the action of the bacteria. So the patient will be having no turbinates normal size. So this, because of the absence of the normal size of the turbinates, there will be roomy nasal cavity. A patient presented with epistaxis that doesn't stops on nasal pinching. So they are mentioning here the Trotter's method. This is the Trotter's method. First aid that should be given for any epistaxis. And head down position. This is Trotter's, typical Trotter's position. This was a previous year MCQ. If you would have solved the previous year MCQ, so you would have known that, okay, Trotter's method they are asking. Then it doesn't relieve on anti-nasal packing. So the first, then next line of management is anti-nasal packing. So it doesn't relieve on anti-nasal packing. What is the next line of management? So the patient is having more epistaxis that doesn't stops on non-surgical treatments. So we should try for some surgical treatment. So which is called artery of epistaxis. So the artery of epistaxis is sphenopalatine artery. So it doesn't mean that maxillary artery, external carotid artery are not that much important, but sphenopalatine artery is called artery of epistaxis. So if you ligate the sphenopalatine artery, most of the times the bleeding will stop. Okay. So we have given in page 149 of our workbook. The first thing is Trotter's method, that is nasal pinching and forward lying position. Then anti-nasal packing done in the nasal cavity in this manner. Okay, this is nasal packing. Then posterior nasal packing. So we should insert a Foley's catheter, should inflate the balloon of the Foley's catheter against the posterior choana. So after doing posterior nasal packing, you should still do the anterior nasal packing for this patient. This is for posterior epistaxis. This is for anterior epistaxis. Okay, test part. So this is the question that was asked today. Transnasal endoscopic sphenopalatine artery ligation. Fine. So this is the first artery that you should like it. So this is the nasal cavity of the patient. So here we will be using the inferior turbinate. So you should reach the, this is middle turbinate. You should reach the posterior end of middle turbinate. Then you should apply clips or cauterization. So this is the procedure that we would do in test one. Okay, so the landmark is posterior end of middle turbinate. So again, epistaxis proved to be the most important topic in rhinology. They have asked another question. So ligation of other arteries, we can ligate. The next artery that we could ligate is anterior ethmoid. So that artery can also be the culprit. Then anterior ethmoid is a branch of ophthalmic. We can't do anything. Most of the branches, sphenopalatine artery, craterpalatine artery, are branches of maxillary artery. So maxillary artery ligation can be done in the next order. Then straightly all these maxillary, facial, all are branches of external carotid artery. So external carotid artery ligation can also be done. So that explains the that question. The following area on touching the following area has pain and dysphagia. Okay, the patient is having pain and dysphagia on touching this area. So what could be the possible nerve phenomenon? So it probably shows the oropharynx. So oropharynx is supplied by possibly glossopharyngeal nerve. Larynx is supplied by vagus nerve. Okay, obviously vestibulocochlear nerve is for ear, hypoglossal nerve is for tongue. So it is nothing but they are giving the gag reflex. So 9th nerve and 10th nerve is responsible for gag reflex. So 9th nerve oropharynx, 10th nerve larynx. Okay, so this is given our page 107 of our workbook. So see here, this I have given for referred otolgia. So if you study referred otolgia, you could easily remember the important nerve supply of the head and neck region. Okay, so glossopharyngeal nerve supplies the tonsillar fossa and other parts of oropharynx. It also supplies the middle ear. So middle ear, it supplies the with Jacobson branch. So larynx, which supplies the which is supplied by vagus, is also supplied by Arnold branch of vagus, which supplies the external auditory canal and pinna. Okay, so a part of pinna. So it's mostly for external auditory canal. Sometimes pinna, but not prominently pinna. So pinna is mainly by greater auricular, lesser occipital, and then auriculotemporal. Fine. So why I am telling this? Because so if you read it together, you will not forget. So again, trigeminal mandibular nerve. So auriculotemporal nerve is a branch of mandibular nerve. So it also supplies the mandible as well as ear. So auriculotemporal nerve major supply of pinna, that you should remember. Fine. Post-tonsillectomy patient had peroral bleed after 2 hours. So you are going for a post-op rounds for the tonsillectomy patient. On examination, clots were present in the tonsillar fossa. So what is the immediate line of management? So clots only present. If clot only present means, then you can wait for self-extrusion of the clot with usage of oral mouthwash with povidone iodine. Okay, if there is only blood clots were present, then you can wait and watch so that the clot will come out on its own. If there is an active bleed, then you should immediately stop that bleed. So if the patient to OT, remove blood clots, that is not enough. So if the patient to OT, you should ligate the blood vessels. What are the blood vessels that are mainly causing? So tonsillar branch of facial artery, ascending palatine artery, descending palatine artery. Then ascending pharyngeal artery. So these are the branches that are supplying the tonsillar fossa. The most common is tonsillar branch of facial nerve is the most common artery that is responsible for post-tonsillectomy bleed. If they ask vein means, we can tell it as paratonsillar vein. But here you should definitely ligate the vessels if you find active bleed immediately in the emergency theater. Okay, so which is given in our 230 workbook, where the bed of the tonsil and tonsillar blood supply are explained. A topical application of following. Now we are okay. Now the topical application of following drug used in treatment of. So mitomycin is given in the question. Options are rhinocerebral mucormycosis. So I was expecting a question from mucormycosis, but it was given as an option. So some people would have confused that, okay, mitomycin may be given mucormycosis, but never like that. So it is not given in tympanoplasty, not given post-thyroidectomy. It is given in subglottic stenosis. So the mitomycin will have some anti-proliferative properties. So if there is anti-proliferative properties, the stenosed part can heal. It can return to its normal caliber. See, this is the subglottic stenosis. So this is given our 238 workbook. So if we give mitomycin injection topically, it can reduce the proliferation of the cell, reduce stenosis. So these are the possible things that you could expect in mitomycin administration for subglottic stenosis. Okay. A 12-year-old child presented with difficulty in swallowing and presented with following X-ray, and X-ray foreign body that is found to be a coin. So like this, in coin we should take X-ray anterior view as well as lateral view. Right. So this question, if this is only given, means it is not trachea. So trachea means the patient will not be comfortable, it will be uncomfortable, it will present with respiratory distress, okay. So if this is only the scenario given, the answer will be esophagus. So there are constrictions of the esophagus mainly at the level of cricopharynx, that is the starting point. It is most common area for foreign body lodging. If they have given cricopharynx in the option, cricopharynx will be the answer. So cricopharynx is a muscle of a part of inferior constrictor. We can consider it as a muscle also. So if that is given, means that will be the answer. So here esophagus is given. So esophagus, cricopharynx forms the first constriction of esophagus. So we can write it as esophagus. So soft tissue neck mediastinum, it shows perforation caused by the foreign body. So while perforating the soft tissue of neck, it can enter somewhere or it can enter into the mediastinum. So it shows perforation caused by the foreign body. It could be a sharp foreign body, maybe a mutton bone or chicken bone, right? So so these are the things asked in foreign body coin. So this is given in our 249 page of our workbook. Okay. So this is an important question. So after total thyroidectomy, so in total thyroidectomy, what we will remove? We will remove 2 lobes of thyroid. So which is the most important now that comes parallelly with our thyroid gland? So it will be recurrent laryngeal nerve. It passes in the tracheo-esophageal group. So while approaching, because in total thyroidectomy, we will not preserve thyroid tissues. If we look upon to remove the entire thyroid tissue, we are bound to damage this tracheo-esophageal groove where recurrent laryngeal nerve is running through. Fine. So if one recurrent laryngeal nerve is palsied, the other can compensate. So that will be normal. The patient will relieve. If there is superior laryngeal palsy, the supply will study in the next slide. So if there is unilateral recurrent laryngeal palsy, the opposite side will compensate. So the patient will come out of anesthesia effect, that is extubated properly. If the patient is not extubated, can't be extubated, goes for cyanosis and respiratory distress, it means that it is going for some respiratory distress which is having stridor. So both the vocal cords are palsied, both the vocal cords are in this paramedian position. In paramedian position, no space for breathing. So the patient goes for distress. So that's why this patient, during surgeries, they would have damaged the recurrent laryngeal nerve bilaterally. Unilaterally means no problem. Bilaterally, they have damaged. So that could be the answer. So this is given on 239 page of our workbook.